So, good evening, friends. Welcome to this Tuesday evening sessions from the Critical Care and Department of Critical Care Medicine and other allied specialty Yashoda Group of Hospitals and senior colleagues across India from different parts. So, we try to bring topics of interest for all of us from the students as a masterclass and for clinicians like us who are practicing these kind of voice sessions from senior colleagues. So today we had an interesting session, and for my surprise, the before time attendance was more than 80. So before the session started, there were more than 80 participants. The reason for that is none other than the three legends who are with us in this session. Dr. Rahul Pandit sir, he is a known name in the field of critical care medicine from our medical school days. Rahul sir now heads the department as a chair in HN Reliance Hospital in the city of Mumbai, and he has been a part of all the academics sessions from length and breadth, has been what an academician for the core. Welcome you, sir. It is a privilege and honor to have you on board, sir.
Thank you very much, Dr. Venkat. Thank you. Thank you for the invitation. It's a pleasure to be here.
Yeah. I also invite Dr. Pradeep Rangappa, sir. He has been a dynamic academician with a different flavor. The videos, the PPTs, the way he teaches has been inspiring to many of us. We have been chasing him to know the secret behind the way he is creating these all academic sessions. I think that remained to be $1 million secret for him. One day we will want it to crack. Sir, it's a privilege for us to have you on board, sir. Thank you.
Thank you. Thank you, Venkat. Pleasure to be
Srinivas,
here.
sir, sorry for making you inconvenience, but I hope you will quickly be a part of it. For us in the city of Hyderabad, Dr. Srinivas Samvedam was the light when we were in the part of post-graduation, and many of us took this critical care looking at him, and he has been a shining star for this city, not just as a clinician, but as an academician, teaching all of us across the all generations after him to make us this be here at this junction, sir. It is also a privilege and honor to have you on board, sir, to discuss this topic.
Thank you, Venkat. Thank you for having me on this webinar and this program. Thank you. Happy to be here.
Yeah, so we will, this is a topic which is not a conventional scientific topic, which we thought ki need of the hour. And to our surprise, we could see almost a full house much before the session started. The first question is, sir, the critical care medicine and intensive care has evolved over the last 50 years. I say some of our senior colleagues like Dr. Manimala ma'am says it started way back in 70s, 80s in India, in the institution like AIMS and Nizams, where a small post-operative ward or an area with a few beds with some monitoring tools were considered as an intensive care. From there, specialties like anesthesiology or a medicine colleagues and a pulmonology colleagues used to take care of these ICUs. To in 90s, where Society of Critical Care Medicine, that is ISCCM, has taken up for this diploma courses, from there to fellowship courses, and then we have seen in 2005 or so, the MCI came with FNB courses, to recent times of both a super specialty of DM recognition and DRNB recognition. Rahul sir, this was a journey from those earlier days of this is an undifferentiated specialty where anesthesiology colleagues used to intubate, put lines and resuscitate, and then physicians used to take over and do whatever can they do and call the anesthesia colleagues SOS. This is what even in early part of my career used to see in most of the ICUs. So how do you see this evolution of Department of Critical Care Medicine in India?
Thank you, Dr. Venkat, and thank you to all the panelists. All of you are my friends. So, look, I think the time is already come, and we are now on a very steep rising curve where the Department of Critical Care Specialist, Department of Critical Care and Critical Care Specialist are an integral part of the hospital ecosystem. I would say that they are actually the central pillars around which the hospital functions. So, I keep on giving this analogy, and I would probably use, I'm sure some other people may have used this as well, but I like to use the analogy that if you are wanting to drive a Ferrari car, you require a good seat belt and a good brake. And the seat belt is for safety, and the brake is to sort of know when to stop and what not to do. And that's what critical care department allows you to do. Critical care department is your safety net of the hospital. That's why your surgeons can do things. That's why your cardiologists can go and operate. Cardiac surgeons can go and operate on ambitious surgeries. Oncologists can go and do maximum amount of chopping up and then bring a patient back to ICU. Complex medical cases can be treated because you have a safety belt of intensive care. And then intensive care also knows where to stop, where the treatment becomes futile, and where you actually try and change the course of the treatment towards comfort and more humane angle. And that's where the critical care again steps in. There is no other department in the hospital or in the medical fraternity which does both of these jobs excellently. So I think critical care specialists are no more people who are intubating and putting lines in. They are very much a part of the central decision making. In fact, many of us are in a position where the hospital doctors rely on our judgment for a lot of things, whether it is before the patient has been transferred to us, whether it is before a patient being admitted to us. Of course, during the course of the treatment, they rely heavily on our judgment and our treatment modalities and suggestions. And then, of course, as I said, end of life care is pretty much becoming, palliative care is still in a very nascent stage. I think that end of life care, some of it would be taken up by palliative care when they are more and more specialists. But right now, end of life care, where to stop is pretty much a critical care department. So I think we are the brakes and the safety belt of a Ferrari, and the hospital is a Ferrari.
Rightly said, sir. And I think you made such an important, announcement. Most of you, including you as a chair of critical care, we are seeing in the center of such a big organization taking an important role and a part. And that influence of a critical care specialist in an institution is been a inspiration for many of us, sir. And we can see that happening with your journey itself. Pradeep sir, all three of you have seen training both in India and abroad. In 90s, it was always a decision whether the training in India and abroad, and always the abroad scores over India. And I think the Australia used to be a destination of choice, no much debates, no brainer. And all three of you, Dr. Srinivas, you and Dr. Rahul Pandit sir, all three of you have been some part of your career were trained in Australia. So how do you see training in India and Australia? Then we'll come to the job scopes.
Yeah, thanks, Venkat. I think all three of us have been in Australia, Rahul, Srini, and me. So see, when I trained in St. John's, this was in way back in 98 when I joined St. John's. At that point of time, I think we all agree, intensive care was at a very nascent stage. But what really shaped us to take on this specialty, I still remember when we used to be posted in the second year rounds, second year of our medicine post-graduation. So cardiologist used to give reference for a simple cough to a pulmonologist. So this was the pattern we used to see. And my boss, my mentor used to say, these are all single organ doctors, SODs. So I think that was the statement which really got me thinking. We love medicine, and I used to love medicine, and we used to love reading Harrison. And I felt this skill and this art of beautiful medicine as a subject cannot be diluted into a single subject. And this really haunted me. And at that point of time, Venkat, since this is an informal sort of a discussion we are having, there was no structured critical care training program at that point of time at all. In fact, I remember I was a lecturer in St. John's. I went and gave, the only place which had DM, pulmonology and critical care was PGI at that point of time. And I had qualified, and I was on the first waiting list when I was, when Australia opened up. But that was mainly pulmonology. So there was no critical care structured training program. There were a lot of sort of staggered sort of a programs running as a certificate course. It was just starting off. So I really wanted to have a specialty where we look at the whole essence of art of medicine as a science and do some good intervention. So that is how it all took shape. And now it is entirely different, as Rahul has rightly said, because now we have very robust structured training programs across India in the forms of DMs, DRNBs, and the pathway for this was molded by our ISCCM when it started the IDCCM, which was a structured training program under the able mentorship of a trained people or people who have been in ICU for a long time. So this has been a very incredible journey over last, maybe I would say 25 years, where it has really reached to a stage where we can tell ourselves that we also have the best training program at this point of time. But then our options were very limited and we had to look to overseas. And that is when we went to Australia. And Australian program, and Rahul would agree and Srini also would agree, is possibly still considered one of the best training program because it's a very long program. And they had a good equipoise on trying to see how they equip ourselves into good training. Like if I'm a physician, I had to do 1 year of full-time anesthesia, which really gave me the whole sort of essence and grounding on how anesthesia works. And I've done independent lists in anesthesia. And same applied to Rahul also, where if Rahul Pandita was an anesthesiologist, he would have done 1 year of medicine. And that would have given him a good grounding of the history taking, the science, importance of physical examination, so much as physicians we are dinned into. So it just gets you into the level ground. And it is a very protracted training program where when I went, the training program was literally for 6 to 7 years, and they gave us a little bit of an exemption. But India has taken on that, but I still believe even in India, people coming from base specialty, when they're doing DRNB DMs, they should be posted. If they're from anesthesia, they should be posted in medicine. And if they're from anesthesia, they should be posted into medicine of some sort so that they have understanding as to how the innate mind of a physician or an anesthesia thinks, so that would be my submission. But we are on a very good pedestal at this point of time. And I think India is really arrived now. And from here, we need to see how we set new frontiers in intensive care is my sincere submission, Venkat.
There is still a pattern that few of our postgraduates who complete DM or DRNB here spend some years in Australia as a add-on experience and exposure.
Yeah.
It may not be full, maybe a less than 10%, less than 5%, but it's still a pattern. Do you feel that's still a need of the hour? Or
Yeah, this is a very good question. If there are a lot of trainees, I see 131 participants, Venkat. I have sent maybe more than 20 of my erstwhile trainees to Australia. More than 20 have gone, and many of them have become consultants. That was the time when, see, IDCCM, let us be very honest, Venkat. I think all of you would agree. We're all very seniors in this. 1 year is too short a time, ultra short a time. So we cannot say that we have prepared a intensivist on par with an Australian qualified or any other qualified, saying that they have trained for 1 year after a base specialty. Because I'm talking in Australia, after base specialty, they do 6 years, literally. When I was there, now I think they have shortened a little bit. So we have to be sincere. So right now, after having done a robust course of DM, DRNB, if people go to Australia, it has to be with a clear motive. What is it that in addition they would gain? So the answer is, if they want to fine tune certain skills, like if they want to fine tune maybe communication, maybe research, or have an exposure as to how the mindset of people working there, maybe for short term, they can go work there and come back. But definitely I feel having that qualification of FCICM or FJFICM, it was called before, now it's called FCICM. Now, if their intent is to come back to India, I personally believe going for a long-term FJFICM or FCICM at this point of time may not be very valuable when you come back to India, because you may not find a job in India. So maybe for a short time, I'm telling from a very practical sense, maybe 1 or 2 years, come back and have a good position here if your intent is to be in India. But if your intent is to continue to settle in a place overseas, maybe it is their individual opinion. I cannot comment what their choices are. So that's where it would be. But if you want to learn anything new, I don't know if you need to spend 6 years in Australia at this point of time. Maybe 1 or 2 years should be good enough, unless you want to do PhD research and so on and so forth. Maybe you can take comments from Srini and Rahul on this.
Rahul sir, what are the other countries' options do we have?
So look, I think we are very sure that anybody who wants to go and do a training program in critical care should go to countries where critical care is an independent specialty by itself, because then you have a proper, robust training program. So Australia was one of the countries when we decided to go. UK did not have a separate training program at that time when I went to Australia. It was still a part of anesthesia training. But now UK is, of course, opening up. There are a lot of positions which are coming up in UK as well. UK and Ireland both. Canada still remains a very attractive choice. People who want to go through the USMLE path can obviously go across and have the hard way of doing the USMLE and then going and doing the critical care training, which is a part of the respiratory medicine training, usually in US. And of course, there's a critical care society, which sort of has the independent training program as well there, which offers that as well. But I believe I actually concur with with Pradeep that we don't really need to go across unless you have a desire to settle outside. If you have a desire to just be exposed to a structured medical program, a structured clinical setting, then you can just go to one of these countries, be there for a year or two, and then come back. And it is becoming increasingly difficult to go to Australia as well. Like Pradeep has 20
What is the way, sir? That's what my next question. Most of our youngsters, younger generation critical care students are listening to you. Suppose somebody has an intent to go there after a IDCCM, after a IFCCM or a DRNB or a DM, or a junior consultant already working want to spend. What are the ways they can actually approach and go? What is the possibility, chances? Is it too tough to go, too easy to go? What are the stipends they get there?
Yeah, so I can tell you quite in detail about Australia. Rest of the countries, I have a few students who have gone to UK and Canada, but I've got almost 60, 65 students who have gone over the last 15 years who have gone to Australia, and who are now, a lot of them are now have become consultants. Very few of them have even come back as well. So what you need to do is that all of these programs are heavily dependent on a reference system. So you can apply for a job, but if you are being offered a job, there will be a very strict reference check. And that reference is usually given by a person who you have worked with substantially. So if you want to actually go across and work into these countries, you really require to have a very good clinical standing with the person with whom you are working. Because they will only offer a job to an outsider now who has got some exceptional clinical skills. Gone are the days when they were desperate for doctors to come and work there. Now they have enough surplus of doctors, one or two places here and there. They really want to fill up from outside doctor. Otherwise, within the country, they fill up the positions themselves. Like when I was leaving from Australia in 2010, Australia MBBS reforms happened. So they actually doubled the seats in the medical schools there at that time. Now, those children who were at around 2009, 2010, who were in the first MBBS, now have finished their MBBS, have finished their base specialty, and many of them are in critical care training, and there is a whole cycle which is now coming across. So they've got a lot of their own people. Plus, remember, there is this little thought process that critical care is also a very high burnout branch in India. A lot of people in India do not want to take that up as their first choice because it's a lot of hard work. While it is true outside as well, but the quality of life for a critical care specialist outside is still quite protected. You would not be doing daily calls. You would not be on call for 365 days a year. You would be doing an equitable call of say 1 in 4, 1 in 5. So it is still not a specialty which is looked down upon. Yes, there are some better specialties which people want to take up, but critical care still remains a very attractive specialty. As far as stipend or as far as a job, if you have been offered a job in Australia, you will be on a paid job, and that payment will be as per the government, the state government's salary standing. Usually post MD or post IDCCM, if they take you, you would be taken up somewhere between year 2 to year 4 registrar, and that's a more than adequate salary for you to sustain with your family and maybe perhaps save a little bit as well. So it's not, the money is not the question. The question is how do we get there, because there are many jobs which are being offered for people from outside now.
Srinivas sir, so you can unmute. Sir, can you hear us, Srinivas sir?
Yeah, I can.
So the topic of the payment, job satisfaction, and comparing the opportunities abroad and India. So students will probably like to know from you. So how is it different? We have a different atmosphere. It may be heterogeneous in Indian circumstances, but how is it different, at least in a gross way, from Indian context to a Western context in the job satisfaction and a pay comparison?
So, what happens in this context, Venkat, is it depends on what is your indices of satisfaction, right? If my index of satisfaction is to take critical care to where it actually is needed, to deliver high quality care to those patients who do not have access to it in this country, and to set standards and to improve the systems in this country. If that is what gives you satisfaction, then there's no place better than India to work.
Okay.
Because the with the advent of NABH and JCI, the need for quality standards, the need for adherence to quality is supreme, and nobody can deliver that in an ICU more than or better than a properly trained and credentialed ICU consultant. So that is one aspect. But what is missing in India, and what is very common and very obvious in the West, is discipline and punctuality, which we lack in this country. For example, whether in the UK or in Australia, if the morning round starts at 8 a.m. or the handover starts at 8 a.m., every single person involved in the handover is at the bedside at 7:59 at bed number one. That's how that's something which nobody needs to prompt somebody to come on time. That is something we need to learn from them. Second point is the safety focus. Every single intervention you do, every single prescription you write, or every single interaction with the patient you have has an element of patient safety incorporated into it, and the nurses are the eyes and ears of the ICU. So you need to accept that safety is an integral part of delivering high quality critical care, and you need to respect and uh, uh, take the opinion of the nurses and involve multidisciplinary teams in the care of the patient. So if you can learn that from the West and bring it back into this country, I think we would have done a fantastic service to those units and patients who need that kind of help in this country.
So
As
three
far as
plus.
pay is concerned, you raised the question of pay. There is no comparison between what you get here and what you get there. There is no doubt about it. But I personally feel that the quality of life you get by spending time here with your people, with your pets, with your atmosphere, I get satisfaction out of it. So it's an individual.
Srinivas sir, just in between, nowadays we are seeing some of our Hyderabad junior colleagues also are looking forward for the Middle East, and many of them go for a period of few years to make. So what are those options? And we are not just talking about West Australia and other parts, but some of these intermediate options. We see some of these Middle East, Dubai, other options also. So
Again, the Middle East is seeing a paradigm shift in the way their hospitals are being operated and run. A lot of American based big hospitals like Cleveland Clinic and Mayo Clinic have set up their units in the Middle East, and they know that India runs a robust critical care training program like the DM and DRNB, and these people are preferred. But the problem in the Middle East is they have a little bit of preference for British trained or American trained
yes.
specialists. So if you have some experience in the UK, or if you have gone to the UK and completed CCT in critical care, you have a better chance of getting a better post in the Middle East. You will get a job as you will progress up to the second in
Yes.
command. You will
Yes.
probably not become the leader of the team in the Middle East unless you have a MRCP or a CCT UK or an American board or an Australian board for that matter. So they are currently looking at one of these overseas qualifications for somebody to become director of the ICU. If your ambition is that high, then your Indian qualification won't help you. But if you're happy to reach up to the second in command, I think the Indian qualifications are enough.
Yes, thank you. So I think you were crystal clear in that. You made three important points. You said time discipline, safety profiles, and nursing standards. These are clearly make out a difference from what most of us in Indian setups we miss. Pradeep sir, specialities. Critical care was a super specialty. Now we are also looking after or looking at again super specializing or micro specializing critical care. You said SOD, single organ doctor. Now in critical care, again, we are looking for a single organ specialist. We are saying transplant, renal, neuro, cardiac, and many more, or ECMO physicians. So how do you see this specialties in critical care? Again, fragmenting critical care into different single organ critical care specialists.
Yeah, I think Venkat, you have framed the question really well. So I have to congratulate you. So this is, in fact, is a issue which, in fact, I've been talking about to my senior colleagues. So whatever are my views right now is my views on how we should look at this as of now. I think we need to. This is a serious problem that is plaguing now. See, anywhere in the world, there has to be a base training. You can't become, say, AVR specialist without doing a cardiology, right? Do we do that?
No,
Or would you become a angio specialist without doing your base cardiology, right?
right.
Or you cannot become a chemo specialist
Electrophysiology.
in some cancer saying that I don't want to do other oncology. I'm just doing lung CA chemo specialist. Would you do that?
No.
So the fundamental question that arises to all our leadership is we can't have sort of a fragmented specialization without going through the rigmarole of a sound understanding of the science of intensive care. I'm very, very clear on this. You have to have a sound understanding of the fundamental science of intensive care, period. And nowhere in the world people would allow you to do some sort of a specialization without a sound understanding of the fundamentals of that particular specialty. So my premise is if someone comes saying, I have done a neuro, I have done an onco, without having done the base critical care specialty, I think we are really, sort of preparing someone for a very dangerous endpoints. The reason I'm telling you. So it's a very important question, Venkat, you have raised. What is happening is, so suppose you train in, say, neuro or onco without having gone through the whole core essence of the fundamental science of intensive care. As a leaders of this society and as custodians of our society, we are creating subservience for another super specialist. So you are a super specialist yourself and you want to create a subservient for a neurologist, neurosurgeon, oncologist, or a transplant surgeon. How fair is that? The way it works in Western countries, you do a base specialty, like Rahul would agree, even in Royal Adelaide where I trained, each intensivist has done their base specialty, but they have special interest and they do research. So I worked with the Marian Chapman, who is a world renowned in a GI critical care, but she does proper research. So it is with research and advancing their understanding of that specialty after the base specialty. I would appreciate if you are doing some sort of ECMO. Take, for example, ECMO. It's a beautiful science. And all our trainees, most of them, I would still agree that they would have done DM, DRNBs, or maybe IFCCM, ED. Then they do ECMO. That's the way it has to be. So you do fellowship in ECMO after your complete base specialty, because the science itself is so vast and the depth and breadth are so vast that we need to have a proper understanding, because everything is interconnected. We don't look in silos. We can't look at brain in silo. Every organ. That's the beauty of intensive care. So we cannot dilute the science of intensive care by fragmenting it and saying this is an organ-specific intensive care. This is hugely fallacious, hugely dangerous, and it is cannibalizing our own speciality and going into an autophagy. So that would be my submission. And I am very clear, and I would want to stop all this nonsense if we are encouraging this.
So what if we integrate? You said you have a base specialty and somebody is interested in some subspecialty area. You integrate. You have a 3 years course. You have a 4 years course. You have
Agreed.
1 year
I'm
of
absolutely
critical
fine, because
care.
that is the area of interest they want to dwell in. Hugely encouraged. I would encourage that. But you say you want to sort of
Only do a
fragment the
brain critical
broad
care.
specialty.
Only
You want
brain.
to fragment it and sort of minimize it to 1 year and call them as some, onco-intensivist, neuro-intensivist. I think I'll be very worried about that science.
Okay, all right. Okay. Rahul sir, we will move forward. There are many queries also with the students who have sent me different leagues of or different levels of critical care is practiced in metro cities, like what you do in HN Reliance or in some of our institutions, cities in the type 2, and then towns and in rural intensive care units. So as a young intensivist, they have a lot of questions in their mind. They get offers from the next layer town, type 2 city, with the double the salary, and they go little away to a rural, they get triple the salary. And in institutions, probably the salaries were not that great, or maybe it is a maybe structured way. So how do you actually try to guide them? How do they place themselves? These are the questions always my students come back and ask me this question. So what do I do?
So again, a very important question that should money be driving the whole thing, or should money actually be offered to you for what kind of work you do and how you do it? So first and foremost, I think we have now reached to a point where majority of the training is becoming standardized, whether it is DRNB critical care or DM critical care. IDCCM, I would say that you need to work a lot after IDCCM to be even comparable to them, to the other specialties in terms of knowledge. Degree wise, of course, there's going to be always a no comparison out there. Once you have a standardization of knowledge, you see it in every other country where the critical care is already an established specialty, that you have rural and you have urban population, and you have rural hospitals and urban hospitals, and there is some incentive of working in a rural area or a smaller town area. So that incentive will always be there, because people don't want to move to a smaller town. The quality of life is moving towards cities, not towards smaller towns. So you will always find that smaller towns offer a little bit higher salary. My submission to the people here is that do not get attracted just by the salary. Money is important. I'm not saying you've got to ignore money, but you've got to first do a lot of hard work and prove yourself that you are worth for the institute. Once your institute recognizes you, the money will flow, whether it is in the same hospital where you worked for a long time, or whether it is another hospital which is offering you a little bit of higher salary. Switching jobs. When people come to me for an interview and I see that they have switched 2 jobs or 3 jobs in the last 3 years or 5 years, it's a no for me. I do not take them up in a senior position, because I know that the moment he finds another person offering him a little bit more, he will actually switch jobs. And then it does not allow you to build up your flair, to build up your practice, to build up your importance in that whole hospital, in the whole department, to say that, look, I look up to this person. A lot of it is how people look up to you, how other specialties look up to you, and then the money will follow. So I think money should be a,
Last.
it's more looks more like that Three Idiots का example, where पैसा तो आएगा, काम अच्छा करो,
कामयाबन.
दिल का काम करो, so that's what you need to do. You need to keep on working. Money will flow. It's not a problem. Money will definitely come through.
कामयाब बनो. ये बाकी सब अपने आप पीछे आते जाएगी. Okay, sir.
Correct.
The other point is, it is not just money. Sometimes the rural and type 2 cities and smaller hospitals in rural setups also do need intensivists. What about that?
100%. So I think I actually respect a lot of intensivists who work in smaller towns, because they do a much harder job than what we do. Especially if their level of training is almost equal to us, or they've worked in the city and then they have chosen to go to a smaller tier hospital. I think they have a more challenging job than what we actually find. What things we take for granted in a bigger town, they have to work hard towards that. They have to actually have a trust factor as well. It's very easy for a small town person to say that I want an opinion from Mumbai, I want an opinion from Hyderabad, and not trust the person who is locally out there. So I think there is a need for people to go into smaller towns and establish yourself. Now, if I see a societal change, I think in India the societal change will take a long time. I still work in Australia, and nowadays I do not get to go to Sydney to work a lot. So I go to a nearby place, which is a smaller town near Sydney. Trust me, the doctors there are respected just as the doctors in Sydney. The population has the same faith in the doctor who is in the smaller town who is guiding them. And when they tell them that this needs to be done, there is no question asked. So that societal change is still not happening because a lot of the times doctors are undercutting themselves and their colleagues. A lot of the times the trust factor is not very high. And I don't see a very quick change of that happening. If you look at the 10 most trusted specialties, 10 most trusted professions in Australia, first is firemen, second is nurses, third is doctors. Where
Okay.
are we in India?
We are much below, maybe.
That's where the satisfaction of job will come up for smaller town doctors, smaller town intensivists, when they are respected for what work they do.
Okay. Srinivas, sir, it's not just a super specialty. It's not just a maybe ECMO clinician, but now I am seeing many of our colleagues, not in just our city, but across, are looking forward for some healthcare management courses here and there, getting into business schools, also learning the healthcare management as a master's, so MBAs, and you have been a part of that also. So, how are you looking forward? See, critical care, anesthesiology, emergency colleagues has been seen as a probably they have been exposed to all the specialties. They are master of all, and they've been a quick fix for any of these admin roles because of their background specialty. So, how do you see as a specialist from the critical care when they get into the HOD role, which you have done, and then as you gray your hairs, then you get an opportunity. Please come and help us as a building the hospital. So you have seen that roller coaster. So how do you guide all of us?
Yeah, thank you, Venkat, for asking that question. Now, critical care is one of those specialties which is tailor-made to become administrator. And I tell you why. A critical care specialist, when he is on duty or on call in the hospital, knows exactly the problems when a patient enters to the hospital to the point the patient exits the hospital. What are your problems in ER? Or where is the shortage of stretchers? What are your problems in the lifts? Where is your blood bank? What are the problems in the blood bank? What is the issues with housekeeping? This entire bird's eye view of the ecosystem of a hospital is a daily activity for an intensivist. And he is the guy who will actually be able to pinpoint where exactly the Pareto chart needs to be acted upon. Now, that is where we need to capitalize on. And we also use a lot of high cost equipment. Intensive care is the specialty where very high cost equipment is used very, very frequently. For example, ECMO machines, hemodynamic monitoring, your ventilators, for example, your CRRT machines, your extracorporeal blood purification filters. So, how to manage the finances of an organization, how to present a return on investment document, what are the overheads and what are the headings under which an ROI document should be prepared. The intensivist is the best person to fill in those blanks. For that, I think a formal training in business administration, hospital administration will help us in growing the organization. It's not only about management. Intensivists are very good at infection control, and we see complex infections very often in the hospital. So we are very well suited to run the antimicrobial stewardship program of the hospital. So if you train yourself in microbiological aspects and antimicrobial, you are an asset to the organization. Finance, for example. So why is this needed? Does everybody need to do this? This comes into picture when a life cycle of an intensivist is reviewed. When you are a fresher, you are much sought after in every hospital because they need you to do those night shifts. In India, I'm talking about in India, you need the freshers, you need the youngsters to be doing the shift duties, the nights, the calls, and all. Then you need a team leader who will then, after 6 years or 5 years of experience, you become a team leader. After that, what? From a completely financial aspect, a CEO or a CFO of the hospital does not see much value in you after 7 years or 6 years. A DM or a DRMB who is 4 years plus is ready to replace you. You will be easily replaced unless you add more deliverables to your portfolio. You become an infection control specialist or expert. You become a quality expert. You go to ISCA. You get your qualification from NABH. You become an NABH assessor. You have a diploma in law. You can do something in finance, or you are a business graduate who can give business models to the hospital. Then you will bring something extra to the table in a discussion so that you then become an asset to the organization. So you continue to grow in your career and you progress, yeah, as an intensivist plus as an add-on asset to the organization.
I think this will inspire many of us to take your path also to add some additional value by adding these all qualifications. I completely agree. I think it's also that many times we come to the rescue for analyzing a case when a really a medical legal challenges comes, a complexity comes, a case management also comes. Rangappa sir, there are many young clinicians who also are looking for entrepreneurship. Entrepreneur, we are lagging behind as a medical professionals, but few of you, and particularly you, I heard many times you spoken about ki, we cannot be focusing on just how a critical care will give us back, but many entrepreneurship ideas. Some of them build small hospital, run their own. Some of them actually outsource the intensive care units. Some also actually share the business model of ICU part with a separate billing. So how do you actually see these all options for a critical care specialist in the Indian context?
Yeah, thanks, Venkat. So maybe for all the trainees, the first step would be to have a sound understanding of our science first before you start divesting into other entrepreneurial skills, because you first have to excel in what possibly you are meant to do, which is your intensive care. But I tell all my trainees, Venkat, that gone are the days where you would say that all your life you have done only intensive care. So even Rahul and Srini would agree, in Australia, actually this horizon opened up to me only when I went to Australia, where we had a big pool of consultants, and every intensive care specialist had a very varied passions. So some could be business, because now the question you have asked is more about entrepreneurial, and some about, most of them, not most, all of them would have different passions. So in India, obviously, the conversation is about the financial sort of gains that you would have with your own specialty. But it is terribly important to match up to or level up to the sort of a financial earnings that all of us would aspire for. One needs to invest into a lot of other channels that would yield you good dividends. So this is extremely important. In fact, I tell all my trainees, you excel in intensive care, but at the same time, start looking at channels that would yield you revenue. So although your question was to look at entrepreneurship, so these revenue channels are entrepreneurial sort of skills that are needed. And so when we talk about entrepreneurial skills connected to intensive care, maybe we'll talk only about intensive care. So the future is very, very bright at this point of time in intensive care, because the future of intensive care, as I see it today, is AI will be incorporated. All of you should be adept to AI. And the second important vertical that India will be looking up to is an integrated network. So this is the buzzword I want each trainee to remember, which means we are all right now sitting in silos. Venkat is sitting in Yashoda, Rahul is sitting in HN Reliance, I'm sitting in Manipal. So very soon we would be talking about interconnectedness of our healthcare ecosystems, where he would be sitting in Hyderabad, and he would be mandated, or he would be having the options of managing other smaller units in some remote area within India or out of the country. Why this is needed? Because we can't create intensivists in every part of the remote corners of our country or overseas. We are even having overseas as a very potential sort of a places where you could be delivering intensive care. And all this is going to happen. I think we have arrived, and this is already happening at a governmental level in a very huge way. This is all to homogenize the care, because we are hugely heterogeneous, and it will be all about, see, the beauty of our specialty is not like others. It's a process driven specialty. It's a system driven specialty, and these processes can be rolled out in a protocolized way in any other place by an intensivist sitting somewhere, and all this would add on to your entrepreneurial or revenue channels. So that is a very important area one should be exploring as a science. And there are ancillary uh, sort of aspects of this, because even the extended ICU care, when you talk about home care, there is a whole rehab explosion that is happening, or the long-term care centers. So who would be guiding the care there? So you could be sitting somewhere and guiding the care there. All this would be yielding revenue channels. So this is an area which possibly one should adopt very quickly. Whilst you are doing this, just off intensive care, I think you should be you should maintain good financial discipline, and every trainee should start investing into mutual funds very upfront, so that you start creating corpuses. Don't put all eggs in intensive care. Intensive care will yield you the base money, but if you want to widen up your horizons to have a good revenue channels, then and I think you should start investing into mutual funds and start looking into these ancillary dimensions which would yield you revenues. If you are a research oriented, if you are a book writer, then of course you can author some of the books and earn from the copyright. So those are all small revenues. We have done all that, but the revenue yield is not too much. If you are interested in Instagrams, Facebook, and you want to create channels, that also yields a lot of revenues. And the revenue yielding, don't rely on doctors like how I do, because I have right now, as I'm speaking, 18,000 subscribers. So that does not yield you any money. So what yields you money is you should have 1 million subscribers, and that will come where the narrative is to a common man, not to an extreme specialist like what I do. I cater my videos to a core specialist, and even medicine people say, sir, many videos I don't understand. You would have spoken very complex things. So my videos are not money making. But if you want to do money making, there are doctors who are talking about very simple things in a very impactful way to the common man. So I have not seen an intensivist doing it in a very power packed way. You know that GI man, I don't know, forgot his name. He's become so popular, Tamil Nadu guy in US. So I would wish to see an intensivist doing, if you are skilled in that, do that. I think that will yield you good revenues. So there are channels. Now, social media is a place. So integrated network, if you are looking at intensive care, rehab is an area where you should look at. And if you are a businessman, you want to explore nutraceuticals, that is a huge area which is unexplored. Some of our colleagues are making it big in nutraceuticals, nutrition and lifestyle. That is a big area. And if you are an author, you want to write books, books is one, copyrights, not a huge money though. But the social media, especially if you are doing reels, focused on a common man, I think that would yield. Even a YouTube videos to a common man. Somehow I have no time to do that, but that will definitely, but it has to be impactful, and it has to touch the core of their sentiment. You would make money. So these are just random thoughts, Venkat. I'm sure there are a lot of things.
There are
Add
questions
something,
related
Venkat.
to, please, sir. Srinivas, sir, there are questions related to IDCCM and MCI. I will come back to you. Rahul, sir.
I'll just quickly add a couple of points. So everything what Pradeep said is absolutely right. There is now a new specialty, not a new specialty, a new career option for our specialty, which is opening up. And it could be a full-time career. It could double up as a part-time consulting as well, where lot of AI firms, because critical care data is now just being incorporated into AI for a last 5 years or so, and you will see that there are firms which are hiring intensivists at a reasonably good salary. And if you see some of the hiring sites, the salary start around 40, 60 lakhs per annum for a full-time job. Part-time, I don't know what they would be offering to help them understand the data and how the data should be actually put in. So a lot of AI companies want intensivists to be there. I think this career would probably boom for the next 5 to 10 years. And then I don't know what would be next after AI, whether the AI would become so intelligent that you would not need intensives to tell what to do. Probably that's what's going to happen. Right now, that is definitely a optional career path. Those who do not want to practice clinical medicine after doing critical care, and there may be a few of them who want to sort of go and do this AI kind of a thing. It could be an entrepreneurial exercise as well. It could be an exercise where they could join a current AI team to sort of build up software which would simplify life for us. So this is for sure that we have to get into AI. If we don't get into AI, we will be replaced by people who are doing AI.
Approved. Absolutely. So we'll come back to for the last 1 or 2 points. Srinivas sir, there are questions related repeatedly to IDCCM credibility, whether it is an MCA recognized, whether what is the legality. I think keep on seeing the questions popping on repeatedly.
Yeah. Now let us look at the IDCCM from a fresh perspective. Last year, the government has actually approached the Indian Society of Critical Care Medicine to define, identify who a critical care specialist is. And as per our position statement and our policy document, the 1 year training, they have considered this as enough training for somebody to be heading an intensive care unit in the tier 2 and tier 3 cities, as well as in places where an intensive care needs a team lead. So this is the government's acknowledgement that a 1 year program is good enough. For that to get into an MCI and or an MCA recognition is a big step, which is multiple layers and caveats and requirements are there. But even in the recent interaction with Niti Aayog, when they were discussing with the ISCCM and several other stakeholders in the healthcare sector about who is an intensivist, the IDCCM has figured very prominently in the list of training programs which are training intensive. So IDCCM sooner, I think it will happen in the next 1 year or so, will become a specialty, will become a qualification which the government will acknowledge as a valid training, and you will be able to register it with your medical council as a practice. Whether NMC gives credibility is a big question, which we have been trying for the last 5 years, but there are certain aspects in terms of how our admissions are done, how the allotment of seats are done, what is the curriculum. These are all paraphernalia. But as far as the legality, it is soon going to become an acceptable diploma.
Sir, before we come to that final point, there is one more question which we'll take. One DM student wants to know, he was an associate professor in anesthesiology in ASI Medical College. Now he is pursuing his DM critical care. He wants to ask whether there is no independent critical care department in ESI Medical College. So what should I do? Whether I should be a part of the Central Institute with the previous job, or should I actually do a independent dedicated critical care in a freelancer way or a private organization?
No.
Something very
the lesson for this is the Nizam's Institute. The Nizam's Institute of Medical Sciences, Hyderabad, did not have a dedicated department of critical care for a long time. Now they have a DM in critical care. So the ESI Medical College is actually very well ahead in this process of getting into super specialty training. The day you have eligibility to apply for a DM seat, it is mandatory to create a department of critical care. My recommendation, advice, or request to our friend who is asking this question, stick there. Do not move. You will become the professor and HOD very soon.
So all three of you, before we close this session, one of the point which we wanted to highlight is you all have been inspiring leadership journey. You are not just an intensivist like many of us. You have been inspiring leaders in your field, and all three of you reached those stalwart layer of intensive care medicine in this nation. Rahul sir, how do you actually guide all those young minds who are looking at you, not just a part of an intensive care team, but your journey of leadership, achieving your legacy?
So, Srinivas, it's not a very easy answer to give because you need to first and foremost lead from the front in your clinical aspect, which is your main thing. People have to understand that you are a clinical leader first. And with the clinical leader, there has to be some amount of emotional intelligence and emotional quotient as well. You need to understand that these people are looking up to you. They have come to work with you, they have come there or they are observing you because they feel that you are actually contributing towards patient care. And the more upright you are, the more straightforward you are, they will actually have that connect with you very quickly. Once you have a connect with them, you need to have your emotional quotient, emotional intelligence with them to guide them in the right way. Lot of the times, people do not allow your junior to actually go across, fearing that they would lose a good person. The fun is in actually letting them go and do it, and you will then realize that there are so many people across the country, across the city who you have worked with, and they look up to you. And it's like a true being not being from a teaching institute, but being a professor by just allowing people to grow around you. I think that's the fine balance that you need to sort of achieve. And everybody will grow. There is always a place at the top. Somebody will come ahead of you, then there will be somebody person who is waiting to go ahead of that person. So never be afraid that somebody is reaching at the top. But there's always a place. You can again go on, bounce back and go on the top. So you don't have to sort of worry about that at all. It's not a race at all. It's your individual satisfaction and your individual work which speaks the most.
Perfect, sir. Allowing others to go and probably leading from the front. I think two buzzwords you said. Srinivas, sir, what is your take on your journey of reaching those leadership layers?
Um, Journey of leadership. First of all, you need to have a focus. What is it that you want to do for this specialty of critical care, right? Do I want only my name to be on every billboard and every placard in the city, or do I want to improve the ecosystem of critical care and the brand of critical care to be improved in my city and my country? That is the first point we should be very clear about. If the second is your goal, you are in the right track and you will be doing a lot of good for everyone around you. Second point, just as a addendum to what Rahul said, train your next generation. You learn something today, teach it to somebody else because whatever skill, knowledge, or information you have should not go or buried or cremated with you. Somebody should be able to practice what you have learned. Teach somebody. Make sure that somebody whom you are teaching is actually better than you. Do not be jealous of that person if he's better than you, right? And everywhere in life, there will be speed breakers, there will be potholes, there will be politics, and there will be backstabbers. Take it as part of the job. The number of scars in your back is testimony to your value, to your honesty, and to your dedication. If you remember that, your job is done.
Pradeep, sir, your
I think
journey and
I think
leadership.
Rahul and Srini have possibly told most of it. So, uh, I mean, what I have always followed, there's only one simple thing, so better myself every day, Venkat. I think this has been the philosophy. All my trainees, you can ask all the trainees I've trained, I teach them a mantra. I tell them every day you're going to chant this mantra. So I tell them every day in every way I'm becoming better and better. So this is the mantra I tell them. You chant this positive affirmation because I need to be better today than yesterday, and tomorrow I'm going to be better than today. How is that going to happen? That's going to happen because you are constantly evolving, you're constantly learning. And I tell my trainees, possibly I'm reading more than you guys because every day we would be discussing, we would be deliberating, and this is the only way to attaining clinical excellence in what we do. And once you attain that Zen state of clinical excellence, then it becomes a very joyful journey about the avenues, about the channels that will open up. Because every day I'm learning. I don't know I tell my trainees either I'm reading on intensive care or reading on other dimensions which are helping us evolve. So this is a mantra I re-emphasize to everyone, that every day you need to look back to yesterday and say, how are you better today than yesterday? And this is a mantra I'm practicing and I'm telling in this group, and because I tell all my trainees, because we have to better ourselves for our team to follow us, and we have to lead from the front, as all of us agree. Leadership is all about leading from the front and have an absolute clarity, because I say intensive care is one specialty where it's a chaotic, it's an absolute chaos, and it's a beauty of this specialty. The essence of the specialty is seeing clarity through the chaos. I think that's the beauty of our specialty. If you have reached that state where you are seeing clarity in the chaos that we are in, I think we have attained that state of excellence. Those are my submissions.
I think three leadership journeys, three different prospectors, and what a wonderful session. We have run the sessions almost close to an hour or so, and we had more than close to 200 participants, and we could actually do this almost close to 300-400 webinars over the last 5 years because of the stalwarts, seniors, and legends like you with so much of wisdom. Today, one more session, which not just for my participants and delegates here, but for me and many of my colleagues, was a wonderful journey. Thank you, all of you, Dr. Rahul, Dr. Srinivas sir, and Dr. Pradeep Rangappa sir, for being with us, spending this time and igniting these young minds with so many dimensions. Thank you, all of you, for this wonderful session.
Thank you.
Thank you, everyone.
Thank you, Venkat.
Bye-bye.
And wishing all our trainees all the best and a great journey in intensive care.
Thank you. It was a wonderful session. So thank you.
Thank you. Thank you.
All the best for those who are taking their exams next week on the 24th. All the best. You are in the right path. The future is bright for all of you.
Yes,
all the best.
Absolutely. Listening to three of you, it enlightened all of us that we are in right path, right branch, in a right time. Thank you all.
Okay.
Bye-bye. Thank you.